Now I'm about to start the webinar to have everyone come in.
Hello, everyone. We are going to start in about 3 minutes. So go ahead and get settled. And if you're having any technical issues, please write them in the chat and we will try to help you best we can. All right, everyone, we're going to go ahead and get started and be considerate of our panelists' time and everything else. So, hello and welcome to the Tribal Opioid webinar series. My name is Ariel Tarango, and I'm a health educator and community outreach specialist for the Arizona Center for Rural Health. First and foremost, we'd like to thank everyone for your support and interest in this topic. The second annual Tribal Opioid Conference was to be held earlier this year on April 30th and May 1st at the Ak-Chin Casino and Resort. Unfortunately, this conference was postponed due to COVID-19 and has been rescheduled for spring 2021. However, we know the issue of substance use disorder and opioid overdose fatalities has not only continued, but in fact worsened since COVID-19. Therefore, our opioid planning committee made the decision to provide substance use disorder education and prevention information through a series of webinars. I want to acknowledge the efforts made by the opioid tribal webinar committee members, which includes Christina Floyd, Agnes Atakai, Jillian Hawkins, Lee Myers, Lorraine Ramirez, Alexandria Ohanan, and myself, Ariel Tarango. I also want to thank the Central Arizona Area Health Education Center and Vanessa Stoll for the assistance in coordinating these webinars, as well as applying for continued education credits. Now, we also want to thank Blue Cross Blue Shield of Arizona for their donation so that we can make continued education credits available for the webinar attendees. Thank you for attending the third of 4 webinar series. Please join us next month for our 4th and final webinar, Tribal Services by Health Plans, Opioid Innovations and Services Delivery. It will be held on January 20th, 2021. Okay, so just some common housekeeping. Due to the number of participants, everyone will be muted. So if you have a question, you can type it in the questions and answers section. I will make sure the presenters receive your question throughout the webinar. They will be held till the end when there is a question and answer section. Please make sure to fill out your surveys at the end of the webinar. Today, the webinar will be presented by the Arizona Center for Rural Health, and I'm very pleased to introduce my colleagues, Benjamin Brady and Lena Cameron. I will turn it over to them so they can give a brief introduction. Thank you.
Hello, everybody. Good morning. Thank you for being here with us. So today we're going to be talking about a little bit about the access to medication and treatment for opioid use disorder, or OUD, and specifically our AzMAT Mentors Program, as well as mentioning some other programs and resources. So just real quick, me and Ben and Ariel are from the Center for Rural Health. We're a part of the Mel and Enid Zuckerman College of Public Health under the University of Arizona. And we've been doing opioid prevention programs for about 5 years now. So we do things like work with EMS and first responders, getting them naloxone and naloxone trained, as well as do trainings for community health workers and representatives for the similar things. And we also have a couple different programs all supporting local opioid prevention efforts that focus on anything from primary prevention to overdose prevention and helping folks find treatment. So let's see. So my name is Lena Cameron. I'm a health educator assistant at the Arizona Center for Rural Health, and I help with a couple of those programs that I just mentioned. And I'll let Ben introduce himself.
Thanks, Lena. My name is Ben Brady. I've been at the center for the last couple of years, working on these projects that Lena introduced. Specifically with the AzMAT Mentors Program as well. And so we're really excited to show you some of our preliminary results from that and talk about opportunities to engage with yourselves or members of your community if they're not on the call today. So for our presentation, we really wanted to leave as much time as possible at the end to answer questions or talk with you about anything that we present, or questions with programs or technical assistance that the center can assist you with. And so you'll get me for the first 20 minutes. This is me up at the top. We'll just do a brief overview of opioid use in Arizona, and what we know about medication-assisted treatment as a wonderful opportunity to improve treatment outcomes and help individuals that are really struggling with opioid use disorder. And what we know about that among American Indian Alaska Natives, and looking at opportunities to access medication-assisted treatment in Arizona. Next slide, please. So these are numbers that you've likely seen, or some version of them. There's a very similar visual diagram that looks like this at the national level. It's just that the counts are different. So what I mean by that is Arizona is following national trends over the last 20 or so years in seeing, except for a brief period around 2010, year-to-year increases, at least for the last 5 or 6 years. This is data from the CDC that also tracks overdose deaths by substance type. And the yellow line is where we see the synthetic fentanyl spike over the last 2 or 3 years that's really driving our upward trend. And so as of 2018, that was when we reached the 1,000 mark, the unfortunate threshold where we got into 4 digits. But I just also wanted to highlight that where we have almost 64,000 cases of diagnosed opioid use disorder in Arizona, that equates to right around 1% of our population. And it's a big deal. It's unfortunate that it's a problem that we, as much as we've been watching it and looking at it, that we're still watching it rise and anticipate seeing use and morbidity and mortality outcomes increasing in the coming years, which makes these type of conversations and the type of programs we'll be talking about today essential. Next slide. One of the things that we wanted to do is to look at what this means at the county level. Sometimes this level of detail gets washed out when we look at national or state figures. And so these are data points that came from the ADHS's Community Profiles Dashboard. So they're current as of 3 years ago, 2017. That's the most current available data that's available in those dashboards. But what I wanted to emphasize within this table is to look at how, down at the bottom, how Arizona tracks with national benchmarks. Across we have 2 columns related to mortality and then 2 columns related to use. So on this first column, opioids contributing to death, in Arizona, we're around 12 deaths per 100,000 persons. So we're a little bit low what's estimated at the national level, but we see variation across our counties. Highlighted in red, Pima and Santa Cruz County are higher than our state mean, our state average. When we look at all deaths that are drug involved, not just opioid related deaths, we are actually at this point higher than national averages, and we see actually a larger range of variation across counties. Again, highlighted in red, Gila, La Paz, Mojave being at the higher end. The other 2 columns, opium use and unspecified drug use. This is just to kind of get a sense for you that not every county is the same in terms of its use risks and overdose risks, and they fluctuate by drug type. And so there's not going to be a single answer for every county, even within our state. But like places like Gila and Pima, for example, when we start seeing the same county with high risk factors across multiple categories, that at least at the Center for Rural Health, that's when we start looking at, okay, if we have a mission to help statewide, where we're looking to focus our attention. Next slide, please. Medication-assisted treatment, defined by, I believe, let me check really quick. I believe this was SAMHSA's definition. They write, it's the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach. That should be tailored, it should be clinically driven, and what we'll highlight here is the evidence that surrounds it. But the point I just wanted to make for the purposes of us today and in introducing the AzMAT Mentors Program is that we've known now for a long time that there's multiple components to effective recovery. And so treatment should involve behavioral health that's tailored to an individual, whether it's group counseling, individual counseling, whether it's being in a residential center. Different patients will have different needs, and to the degree that it's tailored is best practices. But the evidence is clear that when a medication is prescribed in combination with behavioral treatment, we see better outcomes. And the evidence base around that is we see increased patient survival, so fewer overdose deaths, fewer overdoses and fatal overdoses, increased retention in treatment, it decreases illicit opioid use and other criminal activity, and then it increases the type of opportunities that sustain recovery, like employment, not listed here, but included in that is more stable family and social life, and opportunities to have additional social connections. And then last but not least, improved birth outcomes among women who are pregnant. So all of this is to say in a really quick manner, because this presentation wasn't about, hey, Matt's great, let's talk about that for 30 minutes, but was to say, we're starting from the position that MAT is the evidence-based approach to opioid use disorder treatment. Thanks. Next slide, Lena. So when we combine now this opioid use disorder, we covered it geographically within Arizona, but when we look specifically at American Indian and Alaska Native populations and communities, we've seen that this is an at-risk or in-need community. With this first bullet point, that's with the American Indian and Alaska Natives we've observed the largest increase in overdose mortality among all racial and ethnic groups. That's since 1999. So I believe this specific data point was 99 through 2015 in that study. But it's not just a concern that it's high within that community, but also that it's been increasing at a really high rate within that community. And that's what kind of together those first two bullet points emphasize. But again, there's large variation. And so there's large differences across tribes, across reservation communities, and by state. And when we look at what treatment has been available to American Indian Alaska Native populations, there was a study, I think it was 2 years old, when this has been published for a couple of years now, where they reviewed all of the registered treatment programs within tribal communities. And they found that a little less than a third of them, I just saw the note to talk louder. Thank you for that. A little less than a third of the communities have medication as a component of their treatment. And when other researchers have asked, why is that? Or in other words, stated differently, what are the barriers to offering MAT? Within American Indian communities, Alaska Native communities, there were kind of these 3 or 4 reasons that are commonly noted. These are listed in a paper that was a stakeholder review session where they tried to bring people from multiple tribes, from multiple stakeholder groups to explore this question. And this is what was highlighted. That there's an identified mismatch in healing traditions, and it's viewed that medication isn't an appropriate addition to those healing traditions. And this follows from the desire for healing to be medicine-free, or in other words, interpreting an abstinence-only approach as meaning abstinence from all substances, those that are illicit as well as those that are therapeutic. And then there's the historical systemic barriers that have been noted, for decades around limitations in the IHS system, as well as geographic insularity, low provider workforce training, cultural competency among providers. That kind of gets bundled into systemic barriers. And then the idea that the research that has been done in a non-inclusive way. Access to the data, those who participated and whose viewpoints were represented and informed the studies, leading to general mistrust and, again, reverting to looking internally for therapeutic responses and then in many cases leaving MAT outside of treatment modalities that are offered. And so improvement strategies, and one that's often offered the most, I could have, I suppose, listed many more here, but the two-eyed seeing approach, or the idea that that there are multiple perspectives, and when those are engaged and talked about together, or not in isolation of each other, that we can begin talking about how, not only in a tailored treatment way, that maybe one option would be better for one person as opposed to another, but that communities could be open to having additional perspectives come in, and that they don't have to be mutually exclusive of each other. Next slide. And so this was an example of that. This is a group in California that had been collaborating with the American and Alaska Native communities in their state to try and look at how MAT could be presented within those communities in such a way that it would be seen as an opportunity and as a resource, as opposed to an outsider threat to traditional healing and spiritual traditions. And so this is just an example of an infographic in which that coalition was trying to speak to an American Indian audience and say that, look, it's not just medication, but medication is an opportunity to combine with cultural activities, with counseling, and really does have healing opportunities for individuals and for communities. And so it supports recovery. So these type of communications can go a long way in addressing stigma and changing perspectives, and in enabling a two-eyed seeing approach for communities to see that there are evidence-based resources and tools that can be considered. Next slide. So I'll end here. I just a couple of slides that will look at where we're at currently in access to medication-assisted treatment within Arizona. This was a study that some colleagues of mine, myself and a few colleagues at the Center for Rural Health, we were asking the question of where are the clinics physically located within the state, and what would be geographic access to them. So geographic access defined as drive time. So there's three different scenarios depicted here. The one on the left with only the blue refers to opioid treatment programs, or clinics where methadone can be prescribed and dispensed for opioid use disorder treatment. We have a little over 60 of those clinics within our state. I think we have 63 that are listed on the federal treatment locator site, but some of those are located within prisons, so they're not all of them are public facing. So I think we have 58 or 59 that are publicly accessible. And so these are showing where they're at and the amount of spatially, if you lived with any of those blue areas, you would be located within a 30-minute drive to an opioid treatment program. Which is significant to note because the majority of patients on methadone are receiving daily or weekly visits to receive their doses. The graph in the middle, or the map in the middle, that has the blue and the green is representing OBOTs, or office-based opioid treatment programs. This is where opioid medication is prescribed in an outpatient office-based setting. And so this refers to buprenorphine, Suboxone, and other derivatives, where it can be prescribed by a provider and then dispensed from a pharmacy. So these data points were taken from SAMHSA's publicly available data set of data-waived or X-waived providers who hold a license to prescribe buprenorphine. And we used a GIS mapping tool to locate them within a clinic, and then again, map a 30-minute drive. So the addition of all of those outpatient or office-based settings reduced the drive time by over 50% on average for the state of Arizona. So that's significant. But we wanted to look at this hypothetical scenario on this graphic on the right and to ask, okay, how about some of those other clinics in some of our more rural and remote areas? And this could have implications for reservation or American Indians living in more remote areas in Arizona. And we asked, okay, if we know that there's clinics there and we know that there are providers there, and so for this purpose, we used federally qualified health centers. We says, if we were to engage with a provider there, it could be an MD, a DO, an NP, or a PA that has a license to prescribe a controlled substance, and that they were to take the waiver training, how much more would that affect drive time, or how much further would that reduce the drive time? Next slide. And so that was the graphic representation of that. This is the table that shows the specific numbers. So just as an example, so the 4168, that's the number of block groups, census block groups that were mapped within Arizona. And so the average drive time to all OTPs in Arizona was 16 minutes, to OBOTs was 7. But if we take the existing OBOTs plus those hypothetical, what the yellow in that map was, if those, so half of the federally qualified health centers in Arizona have a data waive provider or have potential access to Suboxone, half do not. So if the remaining half were to get a provider who is waived and prescribing, that would decrease further. Now, at the state level, it only decreased by another minute, right? It's from 7.1 to 6.1. But it had a larger effect the more rural you got, which is what's shown on the small rural and isolated rural areas in Arizona, to where we could potentially get, on average, everybody within the state within 30 minutes of a medical provider who could provide access to medication-assisted treatment. And so from that, so this is part of it, is so getting people in place who have the legal capacity to prescribe, that the federal government, the DEA is giving them a license to prescribe. But an additional barrier to the prescribing is whether they feel capable, confident, and comfortable prescribing. And so that's beyond having a doctor in place, we need to have a doctor who's trained and supported. And that's where the Arizona AzMAT Mentors Program comes in. So I'll hand that over to Lena, and she can introduce us to that.
For sure. Let's see. Alrighty. So like Ben mentioned, the Arizona AzMAT Mentors Program was kind of a response to these gaps in access across the state. So the goal of the AzMAT Mentors Program was to increase access to opioid use disorder treatment by increasing providers' capacity to deliver medication-assisted treatment, or MAT. And so this was done by taking data wave providers and matching experienced MAT providers, which either have at least a year experience of delivering MAT or have treated at least 20 patients, with new MAT providers who are also data waived but might not have the same amount of experience. Let's see. So these experienced providers assisted in identifying the specific needs and interests and developed a mentorship plan to address them using the SBIRT framework to help guide their efforts. So these experienced MAT providers were oriented in mentorship in the clinical MAT setting, and all participants were given a comprehensive resource guide that covered items such as stigma, cultural and linguistic responsiveness, trauma, and other statewide supports and organization. So this is just a quick look at the SBIRT framework. And so this is what experienced providers kind of use to guide each of the collaborative consultations, which were the meetings that they had to guide the new MAT provider. And so SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And what this does is these domains encompass the three main roles providers perform in providing treatment. For our program, they serve as a guiding framework for the collaborating providers to discuss where new providers need additional guidance and training. So these are just the areas of support. It's kind of a little bit easier to kind of organize those support efforts. In our first year, we had 6 experienced and 9 new MAT providers from 6 counties, and these covered both rural and urban practices in Arizona. 86 of new providers reported likely beginning or increasing MAT service delivery in their practice. There was a twofold increase in confidence among the new providers for implementing MAT into their practice. And there were high satisfaction scores and all indicated interest in participating in the program again. And so these counties, I have the list here. We have the 2 big ones, Maricopa and Pima, as well as Pinal, Mojave, Coconino, and Cochise were all represented in this first year. So we are now accepting submissions for year 2. This year, we're hoping to get a little more tribal and or rural representation for both new and experienced MAT provider roles. So if you or a colleague would like to complete the interest form, the link is on the slide here, or you can scan this fancy QR code with your smartphone and it should take you right to the survey. And so also on the slide here, we have a little graphic that we've made to share on social media. So if you'd like a little more information before you fill out the interest form, the link down here will take you right to our website and you can see a little bit more information if you'd like, or revisit any of the material that I've shared previously. So these are additional MAT resources, both on the national and state levels. The provider's clinical support system, or PCSS, is a really great hub for waiver training, so actually getting the waiver, as well as a ton of resources to support data waive professionals. There's a webinar archive. They have their own mentoring program, as well as interactive forums. And more. They also offer these roundtables where providers can discuss matters a little more candidly, and that is run through SAMHSA. And I believe they're on year 2 of 3 of their grant funding. In Arizona specifically, the ASU Center for Applied Behavioral Health Policy offers similar services in terms of both getting data waived and supporting waived providers. And they offer downloadable resources for both providers and community members. So they have really cool resources and pocket guides for locating MAT treatment within a local setting, as well as kind of explaining MAT to different community members. There's also a biweekly MAT Echo call with case studies and discussion. So there's interdisciplinary representation to discuss matters surrounding MAT across the state. Let's see. The OR line is also a good resource for providers and community members to receive information directly from Poison and Drug Information Center experts. So this is a 24/7 line where both providers and a community member can call with different questions about treatment, about a negative drug interaction perhaps, and there's guidance available for both of these groups. Let's see here. And as always, SAMHSA and Access offer resources to both locate treatment. They have that list that Ben mentioned of the statewide OTPs, as well as kind of explaining MAT and OUD at large. So I think we're going to open it up for some questions or discussion? Next.
Yes, thank you so much for the presentation, Ben and Lena. So I'm not currently seeing any questions in the questions and answers, but this was definitely a very informative presentation and definitely great to get out to our tribal communities, especially with there being a second cohort coming about. So my question, and it could be with the data, I have one for Ben and Lena, especially during COVID times, could it have we seen evidence of, especially with the Navajo Nation reaching the numbers they did with COVID cases? Is there evidence, or have you seen them kind of hitting it like a dual demic or a twin demic with having to have the epidemic, the opioid epidemic, fighting that and fighting the pandemic of COVID-19?
I think it would, yes, I think would be it would be safe to say yes, but that's me saying, I've seen that data at the state level. And as I've talked to different community providers, that both who operate opioid treatment programs as well as office-based programs, that they have reported COVID initially drove down patient volume, which meant that there were barriers to getting into treatment. And so we had people who had previously been stable who dropped off of and dropped out of and discontinued, as well as lower enrollment rates compared to previous years. So then we had barriers to people getting into treatment who we think otherwise would have been able to get into it if not for COVID. And we've seen multiple county partners. I've sat on calls and seen their data talking about increases in overdose. I just haven't seen any of that related specifically to Navajo County or the Navajo Nation up in Utah or New Mexico. So I can't say for sure, but I would highly expect that it would be true.
Great. Okay. And there is another question that's rolling through, if you can see it, Ben. It is the report that Ben was presenting, is it available online?
It is. It was actually a webinar that I sat in earlier this week, and that's already online. So let me go find the link and I'll add it here into the chat.
Great. Thank you. And then this question is probably a more program-based question. I saw the numbers. I'm actually part of the program as well. We are definitely doing more outreach this cohort this year. But when having MAT mentors in the program, how does that affect the newer or less experienced on a personal level, their confidence, everything else that has come up with them? Do you have data for that, Lena?
So I think that is kind of reflected in the confidence, that 86% report of being more confident in either starting MAT services or kind of ramping it up a little bit in their practices. And just to speculate, this might come from just coming from a similar professional background, so they might understand the logistics behind implementing this kind of program, as well as we really tried coming in to get a better understanding of everything that comes with delivering MAT. So that resource guide I mentioned that was given to all of the providers in the program covered a lot of background information, a lot of clinical information, but also covered a lot of like the funding, the paperwork, making sure all your I's are dotted, T's are crossed. And so I think just coming in with that comprehensive view and also relying on these experienced MAT providers really made a difference to help guide these newer MAT providers.
Great. Yeah. So it sounds like it's definitely a sustainable program, and it gets our newer MAT providers out there and able to help more community members. So there's a question directly in the chat. It says, given the lack of OUD treatment clinic sites on the Navajo Nation, per the chart, what is the impact?
So low access to treatment, generally speaking, it's not we are moving into an era of telemedicine where some of the barriers to access are changing. But as you're likely aware, oftentimes access to treatment is the intersection of multiple barriers. And so there's still questions around how types of treatment and different treatment modalities are presented as options, whether community members are aware of them, what communication or promotion efforts exist, whether stigma exists, and we know from the literature on stigma that exists at multiple levels, among providers, among community members, at a political level, at a community level, neighborhoods that are not interested in clinics coming in and offering, that kind of medicine or the wrong kind of medicine. With Navajo County, the Navajo Reservation, we've known, historically that it's first and above all, it's a spatial problem. So I think moving forward, one of the key questions to look at is, in with training in these type of programs, if we can get practitioners who are receptive to medication-assisted treatment and would be willing to train and be interested in this type of programming, that under COVID policy flexing by both our state and federal agencies, we have opportunities now to provide that through telemedicine modalities. So to the degree that we can engage with stakeholders and pursue those type of opportunities, I think that's a promising avenue moving forward.
Thank you, Ben. And then Jackie Kurth, she put in that ADHS has the 2020 state and county non-fatal and fatal overdose data. So she has the link.
Thanks, Jackie. That helps answer that earlier question as well. Thank you for adding that.
Thank you, Jackie. Our next question, are there currently tribal providers that can be accessed for the new mentees?
Sorry, can you ask that one more time?
Are there currently tribal providers that can be accessed for the new mentees? So are there any new tribal providers that are currently, I believe, is that the question? Is that the question?
So I'll repeat it the way that I heard it. It sounds like the question is, we're in the program, there's experienced providers that new providers are paired with. Are there any tribal providers who are experienced that we could pair new providers to receive mentorship from somebody from the community with a cultural background? We're actively trying to recruit that. We've received interest from Northern Arizona and at least one provider who has ties within, but we're looking for more. So to the degree that you have connections or know of people, or if yourself on this call, we'd sure love to talk with you more.
Great, thank you so much. So yeah, we're definitely looking for new. We're looking for experienced as well. So anybody who works with tribes, definitely welcome.
Because I think maybe I could say that more clearly. The program is designed to allow us to pair people together who would be the best fit. And so when we look at matching people, we take that into consideration, geographic proximity, people who are working in serving similar populations or working in similar practice settings. And we're certainly open to, if you know somebody who you would like to receive mentorship from, and the framework of this program could help guide and orient that collaboration and provide some resources to make it more possible. Yeah, we'd love to facilitate that.
So Lena, go ahead.
Oh yeah, so just really quick, because we didn't really talk about the actual matching process. I might have glossed over that earlier. So it is a pretty, we put a lot of effort into, or a colleague did, into the matching process. There are different things that are weighted. So there are like professional similarities, like Ben mentioned, where you're practicing, maybe what kind of patients you're seeing. But we also include in that interest form different priorities a provider might have. And so those are also taken into account as well.
Thank you for that insight, Lena. Next question, and I might have to help you guys out with this one a little bit, but what outreach has been done with tribal, urban Indian, IHS, hospitals/clinics on the expert pilot program?
So it sounds like that's referring to in year one, what outreach did we do? So we used one of the benefits of us being able to run this program through the Center for Rural Health is that we have historically established connections statewide that are both urban and rural, because our focus is on underserved populations, and oftentimes that's rural, but it's not exclusively. So that also includes urban communities and partnerships. And so when we ran the program in year one, that's why we had a balance of both urban and rural participants. So our outreach involved both rural partners in both geographic areas.
Yes, and along to answer that, like Ben said, it's very great to work at the center. So we have plenty of colleagues that work directly with tribes or have tribal focus. So we have, and who's actually on panels with us, like Agnes Atakai, Joyce Hospodard, who works directly with EMS, who's very involved with expert pilot programs, who goes directly out and speaks with the tribe. We also have Michael Allison at ADHS, who gets us in these contacts, and of course, the wonderful Kim Russell, and everybody, honestly, who's on this panel. And that would include myself, because anytime I go to any of our tribal opioid conferences, meetings, I was talking about the AzMAT Mentors Program. And then, of course, I believe we had her in year one. She's unfortunately at El Rio, but she's still our friend and our partner, Dr. Arredondo. She still helps us and is still a mentor, I believe, to this day. And I might be speaking a little out of turn, but yes, she has helped us, and she has helped us navigate our AzMAT Mentors Program to be inclusive when it comes to tribes. So yes, that's what we do, but we're obviously here, we're speaking to the program. So anybody who wants to know more about this, be involved as a mentor or a mentee, please get the outreach out. Okay, this is from Lorraine in the chats. Okay, past and future tribal opioid and substance use webinars are posted on the Arizona Alliance for Community Health Centers. Thank you so much. They're going to be on the YouTube page. So yeah, we have about 30 more minutes for questions. I don't see anybody else in the chat. Thank you, Dr. Bridget Murphy, for putting in information about substance use, COVID, and health disparities. That helps answer some of the questions, especially when it comes to underserved and tribal populations. So do we have any further questions? Give you guys a couple minutes. All right, it doesn't look like it. So I'm gonna go ahead and thank our presenters. Please do not forget to have the survey, or to complete the survey. And if you are interested in becoming a year 2 participant, either a mentor or a mentee, please feel free to go directly to our website and fill out an interest form. Again, thank you to our wonderful presenters, Ben Brady and Lena Cameron, and thank you to the Central Arizona Area Health Education Center for putting this together. And feel free to log off anytime you want, and we're going to say happy holidays to everyone, because we'll see you in the new year. Bye.
Thank you, Ariel. Thanks,
Thank
everybody.
you so much.